Now, moving on to our next section, we are continuing with the airway management. As you know, in the trauma, the most important is cervical spine and airway first. That is the A of the trauma management. We will be briefly discussing, we've discussed only the jaw thrust and chin lift maneuver in the previous section. Now, once we have done that, do we need to do something else as well? And in this section, we'll be going through what are the oropharyngeal and nasopharyngeal airways, what are the surgical devices and how to intubate a patient, and what are the different surgical indications of procedures to maintain a definitive airway such as tracheostomy. So what is an oropharyngeal airway? It's a curved or flattened hard plastic tube with a proximal phalange which is shaped in size of a whole tongue and pharynx of the posterior pharyngeal wall. This is how it is. Once we've done the chin lift and jaw thrust of the patient, we have to clear the oral cavity of all the debris, hematoma, it could be blood, it could be serous and mucous discharges, and once we have, it could be broken teeth as well. Once we have cleared that, then we pass the first is the oropharyngeal airway. That is basically to push the tongue backward so that it does not obstruct the airway. Its multiple range of sizes are available. Usually lining up is alongside the patient jaw size is actually checked. That is, this from this point of is actually measured. You put it up at the nose level and you measure if it's coming till chin. That is probably the ideal size for this patient. And insert it above the tongue and slipped into the pharynx, and until the phalange rests on the incisors. That is, it's oropharyngeal. That is going into the oropharynx and restoring this airway above the level of the glottis. Nasopharyngeal airway, if for example in any case there is an oral trauma or there is massive pharyngeal trauma and we are unable to pass an oropharyngeal tube, then probably the option is nasopharyngeal airway. It's a soft plastic tube with smooth distal bevel and proximal phalange. It's like this. The important thing is this bevel has to be directed downwards. You cannot direct it upwards. That is to prevent this phalange is present actually to prevent it from disappearing into the nose. Then different internal diameter sizes are available depending on the nostril size. It has to be lubricated with aqueous jelly. Usually the most commonly used is lignocaine, and inserted along the floor. Why? Because it's directed downwards, not upwards. There's of the nasal cavity into the nasal pharynx. The reason is hemorrhage from the mucosa and turbinates. The nasal turbinates may get damaged during passing of this tube. Therefore, if it is passed, it has to be directed downwards into the pharynx, not upward into the mucosa. Now coming to the oropharyngeal suction. Once we have, this is very important because once we've done the jaw thrust and chin lift maneuver, we need to clear the oral cavity for the tube, oropharyngeal tube, and this is done usually by a Yonker suction drain of pharyngeal sucker called as by the name of Yonker suction. To actually avoid damage to the soft tissues, important is of a plastic tube, but do not stuff it and too much into the mouth because still it can damage the soft structures of the mouth and oral cavity. And it has to be done under direct vision, and usually it's ideal to use a laryngoscope along with it. Effective in obtunded patient. The patient is not responding. This is highly effective, and its important rule is it's passed till it can be seen. If you do not push it beyond your visual range, because then you may be damaging some other structures with this tube. Now coming on to the supraglottic airway devices. Once we have cleared the airway, oral cavity and passed the oropharyngeal tube, then before the patient, if it's on the, has to be transferred to the main trauma center or level 1 trauma center, the supraglottic airway devices, although they are not the definitive airway, but they can provide the airway which can be secured for enough time so that till the definitive airway such as ETT or tracheostomy can be done. Usually this function between the oropharyngeal airway and tracheal tube, and as it's a supraglottic airway, which means it's above the level of the glottis, and it can be in form of a laryngeal mask devices or laryngeal mask airway, LMA. Usually second generation devices are available nowadays, but the problem is they do not seal as a tracheal tube is cuffed and lubricated and inserted over the tongue. But the problem is this is not a definitive airway. This can still lead to collapse of the airway at the level of below the level of glottis. The patient may be having an airway obstruction despite having an LMA being inserted over there. Now coming to the tracheal intubation. Passing of ETT is actually securing a definitive airway so that the airway obstruction patient can be relieved of the airway obstruction. But as the procedure is, first chin lift, jaw thrust, clear the oral cavity of all the debris by use of suction drain, pass an oropharyngeal tube, and once you have passed the oropharyngeal, when bag mask, valve mask mechanisms can be used to basically ventilate the patient, and then once by this time then pass the ETT is actually securing and protecting a compromised airway in a trauma patient. Usually used ETT can be only passed by use of endotracheal tube or by use of laryngoscopy. It actually, the important point is, if there is in normal person, if we're gonna pass an ETT, usually a gag reflex would be initiated. So there are specific indications of ETT unless patient is in a coma or patient GCS is below 6, below 8, that the patient probably is in such a condition that it requires airway compromise. If the patient is in airway compromise, and patient may require an airway for the proper ventilation. Nasotracheal intubation has a poor success rate, although if for any reason we cannot pass endotracheal tube, which is more of an oral pharyngeal way, then probably nasotracheal tube is an option. But although it is less been utilized, and also it is not usually indicated because endotracheal tube can easily be passed. Coming to what are the indications of tracheal intubation, that is, what are the indications of securing airway. The first and foremost is where you're suspecting that probably patient cannot maintain his or her airway. This includes apnea, inability to maintain airway by other means, need to protect airway from aspiration of the blood, impending airway obstruction, for example fracture, closed head injury with GCS below 8, inability to maintain adequate oxygenation, and inability to maintain ventilation with face mask or bag valve mask devices. That is what are the simple indications of endotracheal tube intubation. If, for example, the ETT, their patient had some kind of a burn injury and trauma as well, and now there is a laryngeal edema has set in, and we are unable to pass endotracheal tube or even the nasotracheal tube, then what is the option? How can we secure the airway? Because we have to secure airway, otherwise the patient will eventually die. So the next option is, then again, needle cricothyroidotomy is not the ideal option. It's actually a passing of a needle into the cricothyroid membrane. But needle cannot give you the adequate ventilation, but it gives you enough time to arrange for the logistics so that you can go for the definitive airway management such as tracheostomy. This is how it is. This is the cricothyroid membrane, and a needle is actually passed into it, so that enough. It is the insertion of needle through the cricothyroid membrane into the trachea to allow a jet insufflation of the lungs with oxygen. But although it's a procedure which gives you at least a time of, let's see, 45 minutes to 1 hour, maybe 30 to 40 minutes at max, but that is good enough time that patient's airway can be maintained, and you can quickly complete the primary survey and its adjuncts, and you can also arrange for the permanent procedure such as tracheostomy. But used in cases where you can't intubate and can't ventilate, oxygenation is achievable, ventilation is limited. Why? Because you're pushing in oxygen, but there is no actually mechanism by which the carbon dioxide which has built up can come out. Therefore, carbon dioxide starts to accumulate, it causes hypercarbia, and the patient actually goes into a respiratory failure. So this is important, that it's a very kind of a limited maneuver, but it gives you enough time before you can move to another procedure which is called as tracheostomy, which is actually maintaining of surgical airway. Insertion of tracheal or tracheostomy tube through incision in the cricothyroid membrane or into the trachea is basically maintenance of surgical airway. When orotracheal intubation fails, it's a difficult procedure, but adequate ventilation can be achieved, because once we have not able to pass endotracheal tube or orotracheal tube, then we cannot continue with cricothyroidotomy, needle cricothyroidotomy, because that is not going to be effective, going to give us effective ventilation. Therefore, we kind of bridge that needle cricothyrotomy to give us enough time that we eventually go for surgical airway, which could be in form of tracheostomy tube or tracheotomy. And a transverse incision, as you can appreciate over here, can be given in the cricothyroid membrane so that a tube can be inserted directly into the trachea for adequate ventilation. So what are the complications of surgical airway? As it is a surgical procedure, every surgical procedure has some degree of complications. Complications include hemorrhage, damage to the laryngeal structures, false passage formation, misplacement of tracheal tube, surgical emphysema, and barotrauma. In this section, we have briefly gone through how to manage airway. That is, the first assessment is always through the ARM method, that awareness, recognition, and management. You give it a chin lift, jaw thrust, you clear the oral cavity of all the debris, and then pass an oropharyngeal airway. Once oropharyngeal airway is passed, then we move towards the passing of a definitive airway in form of orotracheal and endotracheal tube. If we are unable to pass any orotracheal and endotracheal tube, then probably we have to bridge to go to needle cricothyroidotomy, which is kind of a bridging procedure before eventually moving on to definitive airway management via surgical airway. That includes making a transverse incision and drilling a hole in the cricothyroid membrane and passing a tracheostomy tube. Thank you very much. Keep watching sqadia.com.